Our next speaker is Dr. Kanani Titchen. She comes to us from the city of brotherly love, Philadelphia, right, where you're trained, Thomas Jefferson University, Sidney Kimmel Medical School, did a residency there, and then did a adolescent fellowship at Montefiore. She currently is assistant professor and director of behavioral adolescent medicine at the Albert Einstein Medical School and at St. Barnabas. She's going to talk to us today as a recognized expert on addressing the human traffic issue. Can I? Give her a southern welcome. Come on.
Good morning. Yes, I am coming from the city of brotherly love, but I actually now live in New York, and I'm still working in the Bronx. Thank you so much for inviting me. I wanted to thank Lisa Cahill, first of all, and her daughter, who I met at a different conference, Stephanie, who also works on the issue of human trafficking, and also Dr. Adair for having me, and all of you for showing up. We're going to talk about human trafficking and how to respond to it and recognize it and respond to it while avoiding the rescue fantasy, which I think is probably a tendency for most of us because we want to fix things in medicine. And let's see if I can get the pointer to work. There we go. I sadly do not have any conflicts of interest. I would love to have some. So at the conclusion of this workshop, I expect that people here will be able to describe the scope of the problem of human trafficking in the United States, learn and understand the warning signs associated with human trafficking, and commit to incorporating an assessment of patients that you deem at risk for human trafficking. Throughout this talk, you will hear some of the voices of actual survivors of human trafficking. All of their names have been changed, but these are their words. So Sarah says, I didn't really see myself as a sex trafficking victim until I was 20 or 21. I didn't really realize because when I was working on the street, you really feel more like a criminal than you do a victim. I'm going to start with a case. This is a patient that I saw in residency, and I am not violating any privacy laws here. Some of the details have been changed. So she's an 18-year-old girl from Mexico who presented with ovarian torsion and a large ovarian cyst when I was on service in Pediatrics. She had multiple emergency department visits over the past year, and she was frequently lost to follow-up. She was known to have an abusive and an alcoholic father. At 12 years old, she suffered depression and started cutting herself. Around the same age, she went in for a dental procedure and was prescribed codeine, discovered she really liked that stuff, and developed an opiate addiction, turning to heroin ultimately. At 15, she ran away from home. She had multiple sexually transmitted infections, some of them sequentially, some of them presenting at the same time at her multiple emergency department visits. And when I spoke to her and asked her about partners, because I wanted to assess her risk factors, she said that she had about 100 partners, and she left it at that, at least 100. She had multiple tattoos with expletives on her neck, on her hands, all over her body, and she was homeless at the time. And I'll come back to her later. So this was the first patient that I saw in my pediatric residency that was a victim of human trafficking and a survivor. I actually had seen human trafficking before this in medical school when I was on my OBGYN rotation, actually. And because I noticed that this was a problem, I started doing research on my own and ultimately decided to do something about it. And so I founded a nonprofit through the American Medical Women's Association called the Physicians Against the Trafficking of Humans, with the explicit purpose of educating healthcare professionals like yourselves about sex trafficking. And since then, we've also expanded to educating about human trafficking, including labor trafficking. I then was asked in my fellowship to please give a TEDx talk on human trafficking, which I very reluctantly did in 2016, and it turned out to be a really wonderful experience and has served actually many people around the country. They're using it for nursing training and other events, so that's worked out very well. Let's start with the definition of human trafficking. First of all, does anybody here work with trafficking survivors routinely? Has anybody here seen a victim of human trafficking in their practice? Okay, a number. Okay, good. Not good that you have, but I'm glad that you're recognizing them. So the definition of human sex trafficking in particular is the recruitment, harboring, transportation, provision, obtaining, patronizing, or soliciting of a person for the purpose of a commercial sex act, in which the commercial sex act is induced by force, fraud, or coercion, or in which the person induced to perform that act has not yet attained the age of 18. And that's through the Trafficking Victims Protection Act, which was passed in 2000, making human trafficking in the US a federal crime. We can think about human trafficking in terms of three different components: an act, a means, and a purpose. So the act may include, and this is not all inclusive, but it may include recruitment, transport, transfer, harboring, and receipt of persons. So what you'll notice about the act is that unlike the word trafficking, which implies that you're taking a person from one place to another, trafficking actually includes even just the recruitment or harboring of a person, so keeping them in one place even, for or by rather a means. So that means can be threat or the use of force, coercion, fraud, abduction, not seen as commonly, but it does happen occasionally, deception, abuse of power and vulnerability, and then the giving of payments. And all of those are for an explicit purpose, which may involve prostitution of others, sexual exploitation like child pornography, forced labor and other forms of labor or slavery, removal of organs for organ trafficking or other types of exploitation. Now, in terms of this chart and the columns, if the person is under the age of 18 and the crime is sex trafficking, you can eliminate the middle column. We do not need to prove force, fraud, or coercion under federal law. All we need to show is that a person maybe was kept for the purpose of child pornography and filmed online, and that would constitute human trafficking under the federal law. State laws are a little different. Most of the state laws are now moving toward coming up to federal regulations. Human trafficking in poverty. So we can't really talk about human trafficking without addressing racism, misogyny, and poverty in this country. And so the underlying effects of poverty are enormous. Professor Ann Jeanette Roska, she's a human rights professor and used to be at Colorado, now practices privately. She said, people often think that all child sex traffickers kidnap their victims, but in many cases the children end up funneled into the system by their own families because of extreme poverty. And the global sex trade is as much a product of everyday people struggling to survive in dire economic straits as it is an organized crime problem. And I see that often in the Bronx. Many of the kids that I see who are trafficked are being trafficked by family members. When we talk about the scope of the problem for human trafficking, I'm just going to ask you to take all of these numbers with a grain of salt. Because this is such a clandestine crime, we have a difficulty assessing how many people are actually affected by human trafficking. But in 2017, the International Labor Organization updated their numbers and stated that about 40 million people around the world are globally enslaved. That include sex trafficking, labor trafficking, forced marriage, and other forms of slavery. We think that about 100,000 to 300,000 children in the US are affected every year by trafficking. What does affected mean? It's a great question. Where does that number come from? It's extrapolated from a very small study out of UPenn a couple of decades ago, or over a decade ago. So again, we take that with a grain of salt. That may be the tip of the iceberg. Maybe that's an accurate number. We don't know. We do know for sure that trafficking has been seen in all 50 states and the District of Columbia. We are pretty sure that the most common age for recruitment of sex trafficking, if the person is recruited as a child, that's happening around 15 years old, so around middle school or high school age. And there's a reason for that. Those kids are developing. They're not comfortable in their bodies. They're looking for love. They're looking for assurance. And the traffickers that approach them are expert in filling whatever need, whatever hole is in that child's life, the need for love or approval, and filling it in spades so that they can sort of seduce them into this life of trafficking. We think that women and girls comprise the majority of both labor trafficking and sex trafficking globally. We think that about 85% of US trafficked victims are citizens of the US, and about half are adults and half are children. And we know that trafficking affects every race and every ethnicity. Human trafficking and the opioid epidemic are inextricably linked. There are clear links between the current opioid epidemic and trafficking. Some traffickers may recruit directly from substance use disorder programs in order to find people who are susceptible and are looking for a fix. So people can come into trafficking, as our patient Leela did, not her real name, because they have an opioid addiction or some other substance use disorder. Some people come into trafficking and then their traffickers force them to use substances or even force them to sell substances. And that may mean that they're now being labor trafficked because they're being forced to work in an illegal trade. Some traffickers will actually punish their victims if they do have or have created an opioid addiction by giving them Narcan or threatening them with Narcan. And Dr. Hani Stoklosa, who is an emergency medicine physician up at Brigham Women and Children's in Boston, has done research on this and has some terrific data around that. And then also victim survivors of trafficking, once they're out of the life, they may turn to substances as a way of coping with the enormous trauma that they've experienced. We also know that human trafficking and HIV go very closely together. There are a couple of reasons for this. As I said, most of the child victims of human trafficking are recruited when they're young. They have immature genital tracts that make them more susceptible to STDs, and including HIV. We also know that many of the girls and boys who are being trafficked do not feel that they can insist on condom use from their buyer, and at times their trafficker may charge a little more money for the buyer being able to not use a condom. We also know that most of these kids, or many of these kids, once they do leave home, they may not have insurance, or maybe the insurance is through their trafficker. They may not have access to HIV prevention. They may not have condoms available or pre-exposure prophylaxis for HIV. Human trafficking and homelessness also go hand in hand. Many of the youth that are on the streets enter the life of trafficking through survival sex, so they're trading sex for money or a place to live or something to eat, and they find that they have no protection on the street, and so they then look for a trafficker who has the wherewithal to protect them and help them not to be abused by the buyers that purchase these kids. But the trafficker may have rules about, now I keep your money and I will give you an allowance, or I will buy things for you, but you're going to work for me. And so they get into a trafficking situation. We also know that LGBTQIA patients comprise about 20 to 40% of homeless population. If they disclose to their parents that they're gay, that they're transgender, they're tossed out of the home. They don't have any way to support themselves. They're not yet done with school, so they turn to sex as a way to earn money to buy their hormone treatments that aren't covered by insurance, or that they can't afford because they have no insurance, in order to maintain their transgender status, or again, to look for housing or food or sustenance. So again, with the sexual and gender minority youth, LGBTQ, we see that worldwide, transgender women are especially at risk for HIV, and the HIV rate worldwide for transgender peoples who are trafficked is about 27%, so it's an enormous risk factor. Human trafficking in the US. So this is a heat map that was published by Polaris Project. The red spots connote the areas that have high density of human trafficking throughout the United States. As you can see, the West Coast, the Midwest, the Eastern Seaboard, the Panhandle, my home state of Hawaii, and my hometown of Honolulu are all hot spots for trafficking. You'll notice that over the Dakotas and Wyoming, right there in the top middle of the country, in Montana, there are no hot spots. Why do you think that is? I don't hear anybody shout it out. Low population. And I've had some people say nobody lives there, which if you live in Wyoming and the Dakotas, you're not real happy about hearing that. So yes, there's a low population, but people do live there. What people group especially lives there? Native Americans, thank you, and they live on reservations. And what we know about Native Americans is that they do not need to necessarily comply with federal law, and they also are suspicious of federal authorities for good reason. They're sovereign nations, and many of them are not reporting human trafficking. We now have experts who are working very closely with indigenous populations to try to increase the reporting of human trafficking in those areas. So again, this is a heat map of reported human trafficking. It doesn't include all of the human trafficking that's occurring. There was a terrific film in 2017. It has nothing to do with human trafficking. It was called Wind River. It's a murder mystery about the problem of the Native American women who go missing every year who are not being counted. Terrific film and tangentially related to human trafficking. If we superimpose over the heat map, the map of the interstate highway system, we can see that by and large, trafficking does follow the interstate system, and kids and people are being shuttled from place to place, from city to city. They may not know where they are. They're not told where they're going, and so they may be isolated. That's one of the keys to trafficking a person, is isolating them from their support network and getting them alone. One of the most active groups against trafficking is Truckers Against Trafficking, or TAT. They're educating truckers nationwide to realize that the girls and boys who approach them at some of the truck stops that they frequent are not there of their own volition, but in fact are being trafficked by a trafficker. We also have found, after a little bit of research, that trafficking is occurring in rural areas and suburban areas, probably just as much as it's happening in urban centers. So people think of this as an inner city problem, but in fact it's happening all over the US. Sarah says, I think doctors have a certain idea of what a trafficking victim is. They think it's usually somebody who's a minority, or somebody who's from another country, or somebody who has no family or who's in foster care. So it didn't really enter their mind, even as I was more open. Sarah is now in her 20s, but she was trafficked from the time she was 13 to 21. She is a white Orthodox Jewish girl from Brooklyn who was trafficked by her own community. So you can imagine her walking into your emergency department or your OBGYN clinic with obvious signs of human trafficking, but nobody's really thinking of it because she's not the stereotypical victim of human sex trafficking. Some research has found that 64 to 88% of victims of human trafficking come in to receive medical care while they are actively being trafficked. I wanted to get you the names of that research because I thought you might be interested. There was a study by Lumpkin in 2017, another study by Lederer Wetzel in 2014, and then McKinney Chisholm Straker, who is an emergency medicine physician. McKinney Chisholm Straker put out a study, I think 2 years ago now, that showed that 68% of trafficking victims are coming in for health care. Sorry, wrong way. So recognizing the signs of trafficking, this is a very busy slide, so I apologize for that, but I just wanted to talk about some of the signs. So on the top left, untreated chronic conditions. I think we all tend to roll our eyes when we see the women or the girls who come in with chronic pelvic pain over and over and over again, and we can't find anything really wrong with them, and we don't really think about the differential diagnosis of sexual trauma sometimes, or trafficking. Also, the kids who come in with asthma exacerbations, or who come in DKA because they're not taking their insulin or they're eating junk food. These kids may be actually throwing themselves into DKA or deliberately giving themselves or allowing an asthma exacerbation to get bad so that they can come in for medical care, so that they can be hospitalized and have a couple of nights in the hospital where they can get sleep without being raped. Okay, so it's important to think about those patients compassionately, and to keep in your differential, just keep asking why. Why is this patient not able to take their medication? You may have a child who comes in, or a person who comes in with a history of child abuse or domestic violence. On their physical exam, they have those somatic manifestations: irritable bowel syndrome, chronic headache, migraines, chronic pain. And maybe they have chronic fatigue, which I think we all tend to roll our eyes, again, at chronic fatigue syndrome. Important to keep in mind that trauma may be the cause of this person's ailment. Maybe we have somebody who comes into an adult emergency department or an adult clinic who says that they're 18, but then when you Tanner stage them, they're Tanner stage 3, so something is not adding up. And then you find that they have vaginal lacerations or vaginal wall thinning due to the excessive shear stress from violent sex or violent rape. Rectal injuries may be indefinitely sexually transmitted infection. Maybe they have a fearful, anxious, or depressed affect. Maybe you're seeing a teenager and she refuses to make eye contact with you and you think, ugh, she's such a teenager. People in the trafficking situation are often trained not to make eye contact because that can be misconstrued as a threat. And if you make eye contact with a trafficker, you may then belong to that trafficker. These are people who are not used to thinking of themselves as people anymore. They are thinking of themselves as property. So they may not be able to show you exactly what's going on or tell you. And along those lines, I wanted to talk about the trauma event continuum. When we think of these patients, we need to recognize the immense trauma that they have experienced, and that may help us in a way to realize our own position and our own place in their recovery. If we start at the lower left-hand corner with a single impersonal trauma, that's something like 9/11. It happened to all of us. It happened to us collectively as a country. It wasn't targeted at any one of us. Some of us were in New York City when it happened, and we may have severe trauma from that. Others of us may have been across the country, and we don't really need counseling. We picked up, and we have all moved on collectively, but it did have an effect. A single interpersonal trauma would be something like if I'm coming home from work and I'm letting myself into my apartment and I go to open the door and somebody stabs me and grabs my wallet and runs off. Now I've been physically injured, so I'm going to need medical care. I've also been traumatized, so I may need some sort of psychological care. At the very least, when I come in to let myself into my house in the future, I'm going to be looking over my shoulder because now I'm traumatized by that one event. I didn't know the person, but it happened to me and it happened once. Single interpersonal trauma. Multiple interpersonal single perpetrator trauma would be like domestic violence or intimate partner violence. Happens over and over and over and over and over and over again. It's unpredictable, but it's the same person causing this harm over and over again. To me, it's very personal. What we know about domestic violence survivors is that it takes a very long time for them to choose to leave. And what is the most dangerous time for a survivor of domestic violence? It's when she's leaving, okay? So again, that decision to leave has to be left up to the survivor, to the victim, because she knows, or he knows their situation the best. They're gonna know how and when to do that, and they're gonna make sure they have all of their identification, a place to go, and so forth, and they've planned for it. And if they don't, you're gonna help them with that. Multiple interpersonal, multiple perpetrator trauma is trafficking. It's sex trafficking, it's labor trafficking, the two often overlap. So these are people who are raped 5, 10, 20 times a night by different people over and over and over, and like Sarah, for 8 years from the time she was 13 until she's 21. So you can imagine the immense amount of therapy and resources and medical care that's required for a patient like this, okay? Which brings me to the point that we need to avoid the rescue fantasy. If we have a patient who needs that kind of coordination of care, legal care, psychiatric care, psychological care, social work help, job placement, job training, medical care, none of us alone is going to be able to do that, and none of us is going to be able to do that in 15 minutes or half an hour with a patient. So we have to get out of our mind this idea that we're going to pluck these kids and these people out of their situation and save them. That's just not going to happen. And we have an easier time doing that if we remember the trauma events continuum, and we remember that we are one stone on their path to recovery, one stepping stone for them on their path to recovery. I don't remember which survivor this was, but she says, I won't just come out and tell you what I'm doing, so you have to look closely. How might you recognize me? Maybe I've been here before with an STD or after getting beaten up, or when the pain is bad. Maybe I've been pregnant. Look in my chart and talk to me about my history. So how do we talk to patients? So the first thing I would say is always, always, always ask who the other people are in the room and politely tell them that at some point during this visit they're going to have to leave. You don't want to ask your patient, hey, is it okay if I talk to you alone? Because if that patient is with their trafficker, they're going to say, oh, no, 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 he can stay, it's no problem, because they're trained to say that. Because if they don't say that they can stay, then they may get a beating afterwards. So it's my job as a physician to say, no, 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 I know that you want him to stay. I need him to leave. In order for me to do my job better, I need this person to leave. And if you have any problems getting them to leave, then that's a huge red flag, and then you're going to be calling security or whoever else to try to persuade that person to leave. Or you can get creative with it. So if they're refusing to leave, you can say, well, you know what, we need to take you to ultrasound, or we need to take you to the bathrooms because I need to get another urine sample. The first one wasn't good enough. I'll escort you. So find a creative way to get that person alone to ask them questions about their situation. When we are asking them questions about their situation, again, recognize the immense trauma that they've been through, so restoring control to them and allowing them to decide if they're ready to disclose is key. Providing them a safe space that's private and as quiet as possible, hard to do in some situations. And then also just acknowledging the strength of the patient. Maybe that patient was half an hour late for their appointment. Maybe they've missed their appointments multiple times, but they're finally here. It takes a lot sometimes for our patients to come in. I know my patients in the Bronx have to take multiple buses and walk and take the subway, and so often they get there late and then they can't come in another day or reschedule. So just acknowledge the strength that it took for your patient to get there to see you. And again, can't say it enough, avoid the rescue fantasy. If you suspect a patient of yours is being trafficked, there are definite things that you can do to help them. So the first one is, again, get the patient alone and comfortable. You're going to disclose any mandated reporting obligations to them if they are not the age of 18 or over. You want to do that up front so that you're not, if they tell you something, when I have a 16-year-old who tells me, yes, she's having sex, and by the way, her partner's 40, that I'm not in the position then of saying, oh my gosh, I'm going to have to talk to somebody about that. If I've disclosed it up front, my mandated reporting obligation, then my patient knows, okay, if I tell her this, she's going to have to get help. If I don't tell her that, then she won't have to get help. And that, again, restores control to your patient so that they can decide what they're ready to share. You want to address immediate needs first. So part of that, that first step is making sure they have a blanket if they need it, water, food. A lot of these patients haven't eaten for a while. Many of them are on the street. So make sure that they're comfortable. Universal education is putting up posters in your clinic. In my adolescent clinic, I have posters that list the National Human Trafficking Resource Center hotline, which actually it's right there on the bottom of the screen, 888-3737-888. It's written that way because it's designed to be memorized. So 888-3737-888. They can also text Be Free, which is 233-733. I have those posters up in the bathrooms, so when the patient goes to give me a urine sample, she sits on the toilet and she's looking straight at the National Human Trafficking Resource Center poster. I have them in Spanish and English. Those are the most common languages for me in the Bronx. I have them also in the waiting area because I don't see parents anymore. I'm an adolescent med physician, so occasionally I see a teen parent, but many of the parents who come in are trafficked themselves and they have little ones, and so we have those resources up for them to look at. And that way you're not in the position of trying to figure out, is this person trafficked, is that person trafficked? You're just giving the information. I've talked to teenagers and asked them about their risk factors, and then I've told them I'm concerned about you, and they say, oh, no, 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 I'm fine. And I'll say to them, well, why don't you just take this number anyway, just in case any of your friends need it? And that's a way for them to save face and take the number. Empowering the patient, again, is restoring control to him or her and allowing them to disclose what they want when they want. It's not asking for every lurid detail about what happened to them. If they want to share that, then I welcome it, although I also am sensitive to vicarious trauma, but I tell patients, look, you don't have to tell me anything, but I'm willing to listen. And I also tell them I'm not a therapist, but I can help you get one if you would like somebody to talk to. Supportive referral is that warm handoff. I'm fortunate to have a therapist right in my clinic, so I'm able to introduce Sarah right in real time, and many of my patients follow up with her. It means having your social workers informed and in clinic and able to help. And it involves also getting follow-up information. So one of the problems I had in the Bronx actually was I would get numbers for patients and then I would call them and it would be a burner phone, and so the number would be dead. And I worked with FBI in New York and asked one of the agents, how do I get follow-up information for my patients? And he gave me the idea to get not only a cell phone or a phone number for the patient, but ask them for a phone number of their best friend or a trusted person in their life, and ask them for an email. And I've worked with homeless youth in Harlem and the Bronx. Everybody has an email. Even if they don't have a cell phone number, they have an email. And if they can't give you an email, that is a huge red flag. Schedule their follow-up. Don't say go out to the front desk and make an appointment with me in 2 weeks. Actually write down for them on a prescription pad, you must see me in 2 weeks, so that that person, if they are being trafficked, can show that piece of paper to their trafficker and say, look, I have to come back in 2 weeks to see the doctor. And I find any excuse to see patients, acne, dysmenorrhea, anything, I will find a way to see that patient again. Some of the questions that you could ask for either labor or sex trafficking include, is somebody holding your ID or passport? Has anybody provided, or have you provided sex for money or food or a place to stay? And important to ask that question in a really non-judgmental tone. And sometimes I even tell my teenagers, look, I see everybody in this clinic, all walks of life. And so if this is you, you can let me know. Did someone require you to pay them part of the earnings that you make to them, and is the job or pay different than what you were promised, which is a huge red flag for labor trafficking. When I was in the life, I never told any nurses or doctors. They didn't ask. I don't know if I would have told them if they had, maybe. It depends on if I thought I could trust them, but I do think it's important to ask. So I'm not going to go into these numbers in detail because I know you have the TBI coming to speak, but these are some of the 2013 numbers that I pulled for trafficking, sex trafficking in Tennessee, explicitly of minors. And group one, so you can see on the left is the number of cases, and then along the x-axis there is the counties that are reporting. And so group one includes over 100 cases of minor sex trafficking in some of these counties, Coffee, Davidson, Knox County. Group two, which includes Chattanooga, are the cases, or the counties that are seeing 26 to 100 cases of minor trafficking for sex. And again, that was 2013 data. I'm not going to go through all of the state laws, but you have a lot of them, which is great. And so some of them are basically going back to 2011, saying that if you arrest, say, a 15-year-old for prostitution, they are no longer going to be prosecuted for that. They're going to be considered a victim of human trafficking, again, by nature of that TVPA, that federal act. In 2012, that victims of human trafficking in general now have a defense in prostitution cases. So I believe that's minor or over the age of 18. And then we start to see laws about labor trafficking of minors. We start to see restitution to the victims. So again, most of these victims do not keep their earnings. They turn them over to the trafficker. A trafficker can make about $80,000 to $100,000 off of one victim per year. So they're turning all of that money over to the trafficker. Many of the traffickers then turn around and purchase things, not in their own name, but in the victim's name. So if that trafficker is ever punished and their assets are seized, the property was put in the victim's name, and the victim, therefore, is considered guilty or punishable. So these traffickers are very clever about how they manage their finances. We see also that ignorance of age is no defense. And now we're seeing laws for Johns, that Johns are considered traffickers or participating in human trafficking. So it is no longer okay to say, I didn't know that she was 13. She said she was 18. Just not a defense anymore. 2014, many more laws. Traffickers are, or rather Johns are being placed on the sex offender registry if they do purchase minors. Child abuse laws, so this happened in New York State as well, that human trafficking or sex trafficking in particular is considered a form of child abuse, so it's reportable, and so I am a mandated reporter for that as a pediatrician. We see that forensic medical exams are being offered without charge to victims. In general, so in 2018, we see that victims of human trafficking are now able to get their records expunged, which is huge, which I think Lisa's daughter Stephanie works with a lot in expungement of records, which allows patients to then be able to apply for a job or get a loan, buy a car, all these things that we take for granted, you're not able to do necessarily if you've got a record. And those are the major ones. For the last one, Senate bill and House bill, the privacy protection for human trafficking service providers, so that's key so that there maybe is not so much in the way of retaliation from traffickers against those who have been trafficked or those who provide for them. I would also say just this is not a Tennessee law, but in New York State, a public health law was just passed in 2017 that now mandates that all healthcare professionals who come into contact with victims of human trafficking, front desk staff, security guards, physicians, nurses, now must be trained in human trafficking to understand what it is and how to work with these patients. And I know California is pushing for a similar law. I think it's just a matter of time until we start seeing state laws in many states to mandate that we learn about trafficking. You have a trafficking hotline here in Tennessee. It's 1-855-55-TN-HTH for Tennessee Human Trafficking Hotline. And then again, the national number 888-3737-888. And then also Be Free, to text Be Free. Protocols. So one of the things that you can do for your institution if you're interested is develop a protocol. I know that when I learned about human trafficking, I thought, oh my gosh, how am I ever going to have the time if I encounter a patient who is being trafficked? It's going to suck up my entire clinic or my entire ED shift. So how am I going to move through that? So protocols are key. This is a protocol or a timeline, rather, by Northwell Health, which is a New York-based hospital system. They are training all of their staff on trauma-informed care. So it's system-wide, which is the nature of trauma-informed care. And so, for example, in month 1, they say identify task force members and champions of the anti-human trafficking movement. Month 2, train your task force and your champions, maybe 2 two-hour monthly sessions. And then by month 3 and 4, you're training the whole staff. So they've got a timeline where for that, and this needs to be top-down. It can't be, you know, I'm a little pediatrician and I want to do this. I need to get buy-in from the CEOs and the VPs in my institution to do this. To develop a protocol, Heal Trafficking is a network of healthcare professionals, nurses, doctors, even some lawyers, legal advocates, and social workers who come together on human trafficking issues. Heal Trafficking now has presence in every state. We have members in every state and even multiple countries. And they have a terrific toolkit for how to put together a protocol for your institution. Dignity Health is a healthcare system out in the West, in Arizona and California. They have multiple hospitals, and they also are training their entire hospital system on trauma-informed care and how to work with trafficking victims and survivors. And so they have some resources as well. They published their learnings manual. So everything that they had learned over the years of developing a protocol and working with these patients, they've published for other people to use. And then Via Christi is an organization that has a little trafficking protocol that looks like this. So it's a pocket card that talks about the steps for if you identify a child. This is for child abuse or child trafficking in particular, what to do. And then step 2, the questions that you might want to ask your patient if they're a U.S. citizen or a foreign national. Step 3, if you get any positive answers. And then moving on to step 4, patient does want to notify law enforcement or doesn't want to notify law enforcement, and how do you work with that? This is a protocol or a guideline that I put together for a children's hospital at Montefiore, where I did my fellowship in adolescent medicine. It's quite busy. It could be simplified just by, suspicion in that first column and all those red flags. That could all be taken care of with a training. So the protocols are useless without a training. So if you develop a protocol, you've got to train your staff on how to use it properly. And then in the last column there for disposition, I did the research in New York City and found the organizations that I had most closely interacted with, that I knew had wraparound services, had legal services, and worked with people who were victims of labor and sex trafficking. And I had their numbers in my cell phone, and I've used them many times in my clinic and said, look, I have a 17-year-old. She's being trafficked. I know it. Don't know what to do. She doesn't want to disclose. She's at that really in-between age where technically, yes, I'm a mandated reporter, but if I report her against her will, I will never see her again. So some of the adolescent medicine nuances are tricky. So I regularly consult my legal advocates at Sanctuary for Families and ask them, how do I proceed? And this points to the importance of connecting your patients to services. Again, with that complex trauma that your patient has experienced, they need to have multifaceted social and legal services available to them. Many of them need skills training, job training, so that they can do something else other than have sex for money in order to survive, and they can get out of this lifestyle. And so you can hopefully access your social work department, and they should know about human trafficking and state laws. These are some of your Tennessee resources. Oh, sorry, it made it Tennessee. So your resources here in Chattanooga include the Partnership for Families, Children, and Adults, and the Second Life Tennessee. And then I believe in Knox County is CCAHT and Safe Space. I do not know those resources firsthand, and one thing I would strongly advocate for is that if you're going to use a resource for human trafficking, that you call them, you talk to them, you know exactly what your patient's going to experience before you refer them. And to that point, Polaris is your definitive online resource for human trafficking, and they work very closely with the National Human Trafficking Resource Center, 888-373-7888. If you're wondering what happens when you call that number, call the number. I've called it just to say, hi, I'm a physician, just testing out this number, just wanted to see what happened if my patient calls this. I've texted 233-733 and seen what happens if somebody picks up or answers me. So I would encourage you, I'm not going to tell you what happens because you should just check it out for yourself. And then PATH, Physicians Against Trafficking of Humans, we have a 4-hour CME accredited course for human trafficking awareness and how to do a training, and much more detailed than what I can do in 45 minutes. And we offer that free throughout the United States. We've gone to 11 states so far and about 19 different medical schools and universities to give trainings. It is CME accredited for social workers, nurses, physician assistants, and physicians. And then just finally wrapping up, so the key points are human trafficking, prevalent, happening everywhere, all 50 states, District of Columbia. Victims commonly present for medical care while they're in the life, in actually being trafficked. Red flags may include late presentation of care, lack of prenatal care, repeated STDs or STIs, signs of abuse, and a controlling person in the room who will not leave. New York State, as I said, requires now that hospitals train personnel to identify, assess, and work with victims of human trafficking. And finally, just avoid the rescue fantasy. You're not going to fix it, but you can be that one person who treats that trafficking survivor or trafficking victim with kindness, restores their humanity, and really changes the tide for that person. And we've heard this from many, many survivors who say, there was one nurse in the emergency department, there was one OB-GYN that I saw who she told me everything that she was going to do before she did the exam. She was really gentle, and she gave me the choice. If I didn't want the speculum put in, she said, here, you can insert it like a tampon. You can put it in yourself. And they remember you. And then when they're ready to leave, when their lives hit rock bottom, they may think, oh, wait, I can go into a doctor or a nurse and talk to them because that's a safe person. So Nicole says, my lawyers helped me to clear the convictions I had for prostitution and to get legal status. My counselor helped me realize I was just a kid when I was in the life, and luckily I have a future to look forward to. I got help getting public benefits and in a job training program. It felt really empowering to see a whole team get behind me and support me. And that's Nicole. Thank you so much.
dovetail. So if you'll hold those questions, write them down. I'm sure you have some. Appreciate it so much.
Sure.
Wonderful. If you would, can you stop the video recording?